glands are asymmetrical. One of the right gland is pyramidal and left gland is semilunar in shape. So corticotropin releasing hormone is released, which further releases adrenocorticotropin releasing hormone from the pituitary, which is responsible for the release of adrenal hormones. Alright. So the three zones of the adrenal cortex are zona glomerulosa, which secretes aldosterone, posterior regulation of blood pressure. Main receptor of aldosterone is linear channels, which is located in the nephrons of the kidney. Aldosterone retains salts and water in the kidney, which you already know very well. The second layer is the zona fasciculata, which is responsible for secreting cortisol, which is a stress hormone. It results in hyperglycemic condition in the body. Zona reticularis is responsible for secreting the DHEAS, which is the dihydroepiandrosterone dione hormone, which is responsible for secondary sexual characteristics such as the growth of the pubic hair, axillary hair, secondary sexual characteristics, and other secondary sexual characteristics. Adrenal medulla secretes catecholamines. 60% of epinephrine is released, norepinephrine, and then dopamine. These are the three catecholamines. So in pheochromocytoma, the norepinephrine is released in majority, not the epinephrine. Epinephrine is released in majority, 60% in normal condition, but in pheochromocytoma, which is a tumor, norepinephrine is released in major amounts. Fight, flight phenomenon. They are responsible for fight and flight phenomenon. Tyrosine is responsible for the synthesis of catecholamines. It is also responsible for the synthesis of the thyroid hormones T3 and T4. So the end products of the breakdown of norepinephrine and epinephrine is VMA, vinyl mandelic acid. 24-hour urine VMA is increased in neuroblastoma. HVA, homovenilic acid, is the end product of dopamine. So we have three catecholamines: norepinephrine, epinephrine. Epinephrine is released in majority amount under normal conditions, norepinephrine, and the third catecholamine is dopamine. The end product of the metabolism of norepinephrine and epinephrine is VMA, that is vinyl mandelic acid, and the end product of metabolism of dopamine is homovenilic acid. Alright. The aldosterone regulation takes place by RAS, which you already know very well. The second and the third layer are under ACTH regulation. So first is primary hyperaldosteronism. In the diseases, first we'll discuss about primary hyperaldosteronism. So the most common cause of the primary hyperaldosteronism is bilateral adrenal hyperplasia, and the second important cause is the Conn syndrome. So most commonly, the bilateral adrenal hyperplasia takes place most commonly. All right. So next, Conn syndrome. In Conn syndrome, we'll study the precursors of the Conn syndrome. So for example, we have a case of cirrhosis, and because of cirrhosis the patient has ascites, massive ascites. So the circulatory body fluid volume is less, so the GFR will also be less. So if the GFR is less, then the RAS will be activated and it will lead to secondary hyperaldosteronism. Alright, so if aldosterone is released in response to RAS, then renin, angiotensin, and aldosterone system, then it will be called secondary hyperaldosteronism. PIH is also a cause of secondary hyperaldosteronism. Pregnancy-induced hypertension, Bartter syndrome, Gitelman syndrome are the other causes of secondary hyperaldosteronism. The clinical features of primary aldosteronism, we already studied the two major causes of the primary hyperaldosteronism are the bilateral adrenal hyperplasia and the Conn syndrome. So clinical features of primary hyperaldosteronism are ENaC channels are increased, so urinary loss of potassium and hydrogen will be there, hydrogen ions will be there, headache, hypertension, resistant hypertension, which is resistant to three classes of hypertensive medications, which must include, one of them must include thiazides. The second is the increased urinary loss of potassium and hydrogen ion leads to hyperkalemic alkalosis. So this is the characteristic feature of primary hyperaldosteronism, hypokalemic alkalosis. Right? It will also result in muscle cramps. Preload is increased, right atrium, ANF will be released, which will result in natriuresis. So pedal edema is generally not found in primary hyperaldosteronism. Pedal edema is not found because sodium ion are not retained because of the release of the atrial natriuretic factor. Sodium is released, so edema is not found generally in primary hyperaldosteronism. The next is the polyuria and the polydipsia are also commonly seen in the patients with primary hyperaldosteronism. Okay, alright. So what is the workup of the patients with primary hyperaldosteronism? So the sodium ions will be increased or normal, as we already studied that due to the aldosterone there will be more retention of the sodium ions in the water, but atrial natriuretic factor is also released in response to the stretching of the atrium, that will really result in natriuresis, so they cannot be increase to normal limits. Potassium ion will obviously be decreased because of the increased urinary excretion of potassium and hydrogen ions. So aldosterone is responsible for increase in sodium and decrease in potassium ions. So this is an inverse relationship between the two. There will be unenhanced contrast CT. Unenhanced CT means non-contrast CT. So this is the imaging technique for diagnosis of the bilateral adrenal hyperplasia. Screening test is aldosterone renin ratio. As you already know, aldosterone renin ratio, aldosterone will be increased and renin will be decreased because of the negative feedback to RAS. So ARR is aldosterone renin ratio will be more than 750 picomoles per liter. The values you need not remember, just you have to remember that the aldosterone renin ratio is increased and it is used as a screening test in the primary hyperaldosteronism. Alright, false positive ARR are also seen if the patient is on beta blocker therapy. So the values of the ARR will be falsely elevated as they reduce the renin production. Beta blockers will reduce the renin production, is the other function of the beta blockers. So they will be showing falsely elevated ARR. Investigation of choice in this condition is saline infusion test or salt loading test. Saline infusion test is considered safer as compared to the salt loading test. Okay, so let's move on to the treatment of the patient. So bilateral adrenal hyperplasia, the treatment of choice will be spironolactone or eplerenone in males because spironolactones can show gynecomastia as a side effect. So eplerenone we can also use in males. Conn syndrome, spironolactone, and then we can falling spironolactone, we can advise the patient to go adrenalectomy if there is massive increase in the aldosterone levels. We can also do adrenal vein sampling to localize the tumor before surgery. If we have to do adrenalectomy, then we have to localize the tumor, that where the tumor located. So for that, we'll do adrenal vein sampling. Incidence of osteoporosis is high. Incidence of type 2 diabetes mellitus is also high, and cortisol is also increased. So if along with aldosterone, cortisol is also increased, then it will be known as Conn syndrome. In Conn syndrome, I've already taught you that in Conn syndrome, the increase in the aldosterone levels will be there, and there is other we'll be talking about later. In Cushing syndrome, the levels of cortisol are increased. So if both along with the increased level of aldosterone, the levels of the cortisol are also increased, then there's a fancy term called Conn syndrome, which you have to remember. The next is the Liddle syndrome. So it is a genetic condition, autosomal dominant. ENaC channels have gain of function mutation. So the aldosterone levels are normal. So negative feedback to the RAS, renin will be decreased, aldosterone will be also decreased. Because of the negative feedback, renin will be decreased, aldosterone will be decreased. So the ARR ratio, which was a screening test, aldosterone renin ratio will be normal, because both renin is decreasing, aldosterone is also decreasing. So unenhanced contrastivity, normal adrenal gland, as there is no tumor, but there is a gain of function mutation in the ENaC channels. Treatment of choice is amiloride, which is an ENaC channel blocker, because we do not need to reduce the aldosterone levels here, because they are already reduced. We just only have to suppress the ENaC channels. We have to block the ENaC channels, as there is gain of function mutation in Liddle syndrome of the ENaC channels. So we'll give amiloride, which is an ENaC blocker. The next important syndrome is the Gordon syndrome. Gordon syndrome, in the DCT, we have a sodium chloride co-transporter. Sodium chloride co-transporter in Gordon syndrome, there is a gain of function mutation in the sodium chloride co-transporter in the DCT. So sodium ions will be increased, hydrogen water will also be increased. So due to this, there will be hypertension and there will be hyperchloremic, as the sodium chloride co-transporter channel is showing gain of function mutation. So chloride will also be reabsorbed along with sodium. So there will be hypertensive, hyperchloremic metabolic acidosis, because of the retention of the H plus ions to maintain the electrostatic neutrality. Because the kidneys are reabsorbing more chloride ion because of the gain of function mutation in the sodium chloride co-transporter, they will also retain more H plus ion to maintain the electrostatic neutrality, because of which there will be metabolic acidosis. So hypertension with decreased potassium with alkalosis is seen in Conn Liddle syndrome, I already told you earlier, and hypertension in increased chlorine and with metabolic acidosis is seen in hyperchloremic metabolic acidosis is seen in Gordon syndrome. Okay. So next is the Addison's disease. Addison's disease is the autoimmune damage of the autoimmune polyglandular syndrome type 1. So autoimmune damage of the adrenal cortex, which falls under autoimmune polyglandular syndrome type 1. Autoimmune polyglandular syndrome type 1 shows other features such as hypoparathyroidism, mucocutaneous candidiasis. So the most common cause of Addison's disease is autoimmune polyglandular syndrome type 1, and other causes are isolated autoimmune adrenalitis. Only the isolated adrenal dysfunction can also be there, but more commonly it is seen in a combination which is termed as autoimmune polyglandular syndrome type 1, which shows Addison's disease, hypoparathyroidism, and mucocutaneous candidiasis. The other risk factors for the Addison's disease are TB infection, HIV infection, damage to the adrenal cortex, histoplasmosis. Waterhouse-Friedrichsen syndrome is caused due to Neisseria meningitis. It results in sepsis, disseminated intravascular coagulation, followed by the damage to the adrenal gland, adrenal cortex, which is resulting in Addisonian crisis. So it is an emergency condition, acute emergency condition. Sarcoidosis is also related with Addison's disease. Adrenoleukodystrophy is also associated with Addison's disease, and then sudden stoppage of steroids. So we should not anyhow stop if a person is on steroids, we should not immediately stop the steroid, as the hypothalamic pituitary axis is suppressed. So due to the usage of the steroids, that's why we should not immediately stop. Salt wasting, salt craving, polyuria, potassium ions increase, because it will be the opposite symptoms of the Conn syndrome, which we discussed earlier. Because in Conn syndrome, potassium ions were decreasing because of the increased urinary excretion of the potassium and H plus ion, but here the opposite will take place, that aldosterone is decreased, so potassium ion will be increased, there will be hyperkalemia, H plus ion also will be increased, weight loss and fatigue and tiredness will be there, and postural hypertension will be there because of the salt wasting and salt craving. Cortisol, if cortisol is decreased, there is damage to the adrenal cortex. If cortisol is decreased, then there will be hypoglycemic attacks, rage attacks, because of the cortisol is responsible for causing hyperglycemia in the body. I already told you. So if the cortisol is decreased, then there will be hypoglycemic attacks. Loss of inhibitory control over vasopressin. So this is an important function of cortisol. Cortisol has an inhibitory control on vasopressin. So if there is a deficiency of cortisol, there will be water retention and there will be hyponatremia because of the dilution effect. So if vasopressin is less, inhibitory control of vasopressin is lost because of decreased cortisol. More and more vasopressin will act, more and more vasopressin will cause increased water retention, and this will result. So because of dilutional hyponatremia, in isolated cortisol deficiency, there can be dilutional hyponatremia. Because of aldosterone, the sodium ion was there anyhow decreasing. The sodium ions were anyhow decreasing because of the aldosterone deficiency, because of the decreased retention of sodium in water. But if there is isolated cortisol deficiency, then also the hyponatremia can be seen because of the dilutional hyponatremia. There is eosinophilia, ACTH is increased. So if ACTH is increased because of the deficiency of the cortisol, if the ACTH hormone has partial melanocyte stimulating hormone like activity, so there will be hyperpigmentation seen over the areas of friction, knuckles, palm, rhesus, groin, oral mucosa, etc., cubital fossa. The hormone DHEAS will also be decreased, which will result in decreased libido, loss of pubic hair, axillary hair, etc. So what is the workup of the patients? So sodium ion and potassium ion. Sodium ions are decreased, you already know very well. Potassium ion is increased, opposite of the Conn syndrome. In aldosterone deficiency, factitious hyperkalemia can be seen, sampling error. So potassium ions, factitious hyperkalemia can be seen because for example, suppose we are drawing blood with a very micro bore needle. So if the bore of the needle is very less, the RBCs passing through it can get lysed, and there will be increased factitious hyperkalemia. So we have to recheck it. There can be a sampling error. CT abdomen shows restriction of bilateral adrenals. Investigation of choice is ACTH stimulation test, which is also called as co-syntropin test, which is the investigation of choice in this condition. We give ACTH. If there is the increased serum cortisol levels, the patient is normal. But if the patient fails to rise in the serum cortisol levels, then it means that he is suffering from Addison's. So what is the treatment? The drug of choice is hydrocortisone oral, and IV hydrocortisone we can give in acute emergency conditions and crisis. BP is decreased. For the BP, we can give fludrocortisone. So the causes of secondary Addison's diseases are Sheehan syndrome, which is the damage to the anterior pituitary, which you already know, will be knowing from pituitary, or we'll be discussing it later in pituitary gland. So postpartum hemorrhage leads to decreased ACTH, decreased cortisol, no hyperpigmentation, and the ACTH is decreased because decreased ACTH, there is no reflex increase in ACTH due to the depletion of the cortisol level as it was there in primary hyperaldosteronism. Primary Addison's disease. Here the ACTH is decreased, so there is no hyperpigmentation, pale skin. The next tertiary Addison disease is damage to the hypothalamus. The secondary Addison disease was damage to anterior pituitary. Tertiary is damage to the hypothalamus. AVM rupture, hypertension, sickle cell crisis. CRH is decreased, ACTH is decreased. So here also we will not be seeing any features of hyperpigmentation. The patient will present with pale skin. Cortisol deficiency will be there. The treatment is dexamethasone. In primary Addison's we were using hydrocortisone, but in secondary Addison we use dexamethasone. So let's summarize what we have studied. Primary Addison's is due to autoimmune. Secondary Addison is Sheehan syndrome or Simon syndrome. Sheehan syndrome is obstructive damage to the pituitary, anterior pituitary. Simon syndrome is non-obstructive damage to the pituitary. The tertiary is the hypothalamus, damage to the hypothalamus. So in autoimmune, you already know that ACTH will be increased. In both these other conditions, the ACTH hormone will be decreased because of this hyperpigmentation will be absent in these two conditions, but hyperpigmentation will be present in the autoimmune. So the treatment of choice here is in primary hydrocortisone, in secondary tertiary dexamethasone. So let's differentiate between Conn syndrome and Addison's disease as well. So in Conn syndrome, there is a tumor. In Addison's disease, there is autoimmune destruction of the adrenal cortex. BP is increased here, BP is decreased here. K plus and H plus are decreased, and there is increased urinary excretion. K plus and H plus are increased. Pedal edema is absent here, as I already told you, because of the release of the atrial natriuretic factor. There is natriuresis, because of which pedal edema is not present. Hyperpigmentation is present in Addison's, you already know. In Addison's, hyperpigmentation is present if there is primary Addison's disease. In secondary tertiary, hyperpigmentation is absent. Saline infusion test is the investigation of choice in Conn syndrome. Here the investigation of choice is ACTH stimulation test. Alright, spinal lactone is the drug of choice in Conn syndrome, and eplerenone can also be used in males where gynecomastia is seen as a side effect. Hydrocortisone is the drug of choice in Addison's disease. So that was